Good afternoon. I'm Andy Day. I'm the Senior Director for Healthcare and Life Sciences at Tableau, and it is my pleasure to welcome you to the fourth session of the Healthcare and Life Sciences track at TC17. We clearly saved some of the best for the last. So how many of you know that Johns Hopkins actually employs the largest number of Nobel laureates on its faculty and has been ranked #1 in the US News and World Report rankings for not 5, not 10, not 15, 21 years in a row. So we're very fortunate to have Hetal Rupani from Johns Hopkins delivering this presentation. She is the Assistant Director of Analytics in the Department of Emergency Medicine at Johns Hopkins. And she and her team basically enable analytics to support decision support and process improvement initiatives. And you'll actually see a pretty in-depth review of the transformative work that she has been leading. She has a master's in public health from the University of Missouri and has previously worked at University of Pennsylvania and University of Missouri in similar roles. Most importantly, I'd really like to recognize her for spearheading all of the visual analytics adoption at Johns Hopkins, pretty much single-handedly leading to the enterprise-wide adoption that we have today. So with that brief introduction, Hetal, please take it away.
Perfect. Thank you, Andy. Quickly, let me go through the agenda items, what we are going to cover today. Andy did the introduction. We'll go through some throughput challenges at Johns Hopkins Hospital. We'll see how healthcare analytics helps resolve or uncover all the evidences that we need to address challenges. How we use Lean Six Sigma as a solution for implementation. And what are the benefits that we are received from the implementation, and how we are visualizing for sustaining and monitoring our changes. So imagine you are sitting in a meeting, right? And you are up next for presenting performance metrics. You have made sure your laptop is hooked to HDMI projector. Your slides are up to date. You have gone through your slides, and you are pretty confident about what you're going to present. The previous presentation gets over, it's your turn, and eyes on the room turn on you. You are the focus point. You pull up your presentation, you start going slide by slide, explaining trends and patterns and findings, and suddenly someone stops you and asks you a question. And the question goes something like this: can you go back one slide? Right? You are pretty confident, but a little panicked. You go back one slide, and the real questions start pouring in. Why do you see that trend? Do you know what's causing it? What are the contributor factors? Have you all experienced this? Yeah? I did too. We think we are pretty confident about your presentation until someone stops you in the middle of your presentation. I was stopped one day when I was presenting this slide, and I was asked, why do these orange bubbles exist? Well, we know what those orange bubbles are. We just don't know why it exists. And that's where the story of orange bubbles started. And that's where we started our analytical life cycle to understand what are those orange bubbles? Why do they exist? They shouldn't be there. And these orange bubbles are part of a key performance metrics that we track at Johns Hopkins Hospital, which is called boarding time. So what is boarding time? Boarding time is defined as the time the patient waits in emergency medicine when the decision has been taken that patient needs an inpatient bed. And the boarding time depends mostly on the inpatient capacity. If you do not have enough beds on the floor, the boarding time is directly correlated with your capacity. And that's why capacity management is important. Johns Hopkins Hospital operationalized Capacity Management Office in February 2016 to address challenges related to high occupancy and high demand for specialized and higher level of care. We knew that the patient's acuity and complexity is going up, and we knew that there was gradual reduction in inpatient capacity due to many factors. And we also knew, in addition to the patient's acuity and severity, we had challenges with our tripartite mission, which is patient care, teaching, and research. And add to all those challenges, you have those cultures and traditions that you have established over the period of time that you follow, you adapt, and you don't want to move out of it. So you're stuck right there. Johns Hopkins Hospital is situated in Baltimore downtown, Maryland. We have about 900 plus inpatient acute care beds. We discharge about 49,000 inpatients a year. Our newly expanded adult ED has 67 plus private rooms, 17 bed acute care units, 6 trauma beds, 8 psychiatry beds, spanning over 35,000 square feet. And it is 3 times the size of our old ED. We see about 68,000 patients through this ED. And most of the patients that go through inpatient beds, guess what? Where are they coming from? Emergency medicine. In addition to this, we also carry out about 60,000 surgical cases in our inpatient and outpatient settings. The main source of admission to surgical and neurosurgical services are through operating rooms. And we see about 500,000 patients in our outpatient setting. We are big, and that's why we are busy. Capacity management was a new challenge. It was a new thought that was brought forward to address some of these challenges in a unique way. The first one, there are 4 goals of capacity management: to reduce emergency departments' boarding time, to reduce operating rooms holds, to reduce the capacity-related declines from outside referral facilities, and to align discharges. If you do not discharge patients early in the morning, they are going to pile up. Our baseline data showed that on an average, the patients stay in emergency medicine for about 9 hours before they go up to inpatient beds. Our operating room hold, the operating room hold is defined as the hold. It's the time the patient spends in operating rooms after surgery has been done. Just imagine, patient is in the room, operating room, doing nothing. We are holding up operating room. And we saw that about 55, on an average 55 minutes, the patient is in operating room before we find a bed for the patient. We declined about 55 patients a month. The baseline data showed we declined about 55 patients a month for the patient who wanted to come to Hopkins from outside facility for higher level of care. And we also saw that only 5% of the patients are discharged before noon or 2 p.m. So to track all these goals, the best way of doing is to keep us on track, you need to have a visualization, or you need to share what's going on. So what I'm going to show in next 3 or 4 slides are the dashboards that we created using Tableau that helped us keep on track and see where our performance are. So this is patient discharge process time dashboard. This is the aligned discharge goals. We created many visualization, but one of the visualization that everyone's favorite is, it's working, is this one. As you can see, by hour of day, by different location or units, how many patients are discharged, right? And then we color-coded it by the number of patients getting discharged. Can anyone see what's going on in here? Anybody lean Six Sigma? You see that? It's batching. Batching is an enemy. We also tracked OR hold and PACU hold. So focusing on this dashboard, we track the mean and median time the patient stays in OR, breaking it down by ICU beds, non-ICU beds, PACU beds, etc. And there are many other visualizations that we have. We have broken it down by which operating room has the more OR hold, and so on and so forth. We also track operational metrics, boarding metrics, and the capacity-related decline metrics. What you're seeing here is the occupancy, volume, and length of stay. These three variables work with each other. If one changes, another changes. So let's say, for example, if the length of stay goes up, we know definitely someone's occupancy is going to go up. And what happens if the occupancy goes up? Boarding time goes up, right? It's all interrelated. What you're seeing here is the emergency medicine's boarding time trend, the orange bars, and the black line is the percent of patients getting out of emergency medicine within 4 hours. That's our goal. We want 50% of the patients getting out of emergency medicine within 4 hours. If we do that, our boarding time can be contained. What you're seeing here is the capacity-related declines. The colors are the different services that decline the patients. We don't want to see the increasing trend as we are seeing here. We definitely want to see that we are doing less and less capacity-related declines. But the favorite of all, everybody loved this dashboard because this dashboard actually broke down boarding time into sub-cycle time. What I mean is boarding time is constituted of 3 or 4 different processes. It's just not that patient is waiting for the bed. There are many other processes and workflows needs to be completed. So here is what the sub-cycle time, I can explain you very quickly. What you are seeing pink bar is the time the bed is requested until the time the bed is assigned. That means patient is waiting for a bed to be available. The yellow bar or the green bar shows from the time bed is assigned, have we completed nursing and provider handoff. And the purple bar is once the handoff is done, how much time does the patient take to get out of emergency medicine? And I was stopped one more time when I was presenting this in here, asking me, why are we seeing this trend that's going up? The pink bars. So started analytics work. We wanted to discover what's behind those bars, and we followed this analytics cycle to dig down more, find evidences, and find information, and find what is going on. Why are we seeing increasing trend? I'm going to go through this cycle very quickly. This cycle was conceptualized, designed, and developed by us based on our vast experience working on the challenges that we have. And we saw that there is a pattern and there is an approach that we always took when we had to answer questions. And this is how it looked like when we put it in a piece of paper. So the analytics cycle starts with the problem and barriers. You need to know a problem. Somebody needs to come to you and tell you, well, I have a problem. Or, what I showed you in the previous slide, you are monitoring your performance metrics and you identified a problem. So, starts with a problem and then follows problem identification, deep down into what exactly the problem is. trying to research and explore, talking with the stakeholders, understanding their processes, doing some literature review, or whatever method you want to address your challenges. Go for it to find that you are confident enough that there is a problem. Once you do that, you need to find evidences. You need to quantify. In this age, you can quantify anything. And that's why you need to quantify that. Is it the problem large enough? Small enough? Is my hypothesis right or incorrect? And you will do that by gathering data, doing analysis, figuring out what data elements are affecting your challenge or the problem. Once you have that, then you do deep dive into your data, slicing and dicing and torturing your data, in short, and figuring out what is going on. And once you have that analysis ready, the most important piece is information sharing. Mind it, no one likes to know what you're going to present. I'm pretty sure everybody has gone through it. The first question, are you sure this is correct? Right? So you have to be very mindful when you are sharing your data. You will go back and forth between these two steps, 15 times, 20 times. Don't lose your patience. But eventually, you and your stakeholders will land on the same page and say, yes, we identified the problem, and this is what is going on. And once you have that, you start to identify opportunities for improvement, right? You can't find the opportunities unless you know what you are targeting. And once you have the opportunities identified, you figure out how do you want to implement those opportunities. It could be a Lean Six Sigma. It could be anything. You guys come up with some new ideas. Implement the solution. Once you have the solution implemented, then you will start seeing changes. Changes could start very small, but would expand to where you want it to go. And once you start seeing changes, what you want to do is sustain your change. And to sustain the change, you have to control and monitor your metrics or the goal that you are trying to accomplish. So we followed this cycle. And in our case, we already had the dashboard. We already knew what the problem is, but we needed to deep dive into data. We wanted to either accept or reject our hypothesis that is the increasing trend a real increasing trend, or what's going on with the trend. And we thought that we needed some more data. Data it is, right? Data is new oil. Is that what we heard today morning? And we observed the real process of the bed assignment. I want to remind you, the pink bar, we are still doing the pink bar. Pink bar is the bed assignment process. So we went in, we did all the work, we put down the process and workflow, and we thought we knew exactly what's going on before we started this observation. But then we identified, there are 3 ways you can assign a bed. Either the bed is occupied currently, or the bed is clean, or the bed is dirty. So with this new information, we went back to the drawing board. And we started slicing and dicing data. We just used Tableau to its fullest. We used Tableau extensively to do data discovery. We plotted, we created different visualization to find any correlation. We built histogram to understand any distribution or the events that's occurring frequently. We plotted the trends by using variables on top of each other. And we just went in. We just got inside data. So at this point of time, we were confident that we have our initial analysis, we can take it back, and we can share the information. So we shared the information. So a couple of minutes, I mentioned that there were 3 paths that you can assign a bed. One was clean, dirty, and occupied. And what struck us while doing this analysis that, oh my gosh, If a bed is clean, why does it take 4 hours to assign a bed, right? It's no-brainer. If you have a bed clean, ready, it should be filled immediately, right? So we thought that it's better if we focus on the clean portion of that path and see what the committee or the team has to say. We slice and dice data in a way, easy to understand way. So when we presented this, somebody in the meeting said, "Oh, that's bed downtime." And we were surprised that, yes, this was actually a bed downtime. The time the bed is idle, not occupied, ready. If we reduce this bed downtime, we would save 2 hours of our boarding time, our process time, and we could get 45% of the patients out of the emergency medicine within 4 hours, meeting our target. So we went back and we came and we had another visualization for the team to understand what are we talking about. So this is how we presented. We said, here is where the process starts. Bed request comes in, then the bed becomes available, then you assign a bed, and the patient departs ED. So between the bed request and bed available, we saw about 230 minutes wait. Oh, it's capacity. Then from bed available to bed assigned, it took 180 minutes, 3 hours. And from bed available to ED depart, it took another 90 minutes. Focus here. 54% of the total boarding time was due to processes. And 46% of the boarding time was due to capacity not available. So orange bubbles, back to orange bubbles. What we identified and shared with the committee through this analysis was hidden capacity. We were not filling a bed faster enough for the patient throughput, efficient throughput. The patient waiting in the emergency medicine to occupy that bed was not getting into that bed because we were not able to get the patient out. What we had uncovered, the hidden capacity, it wasn't visible to our naked eyes. It was there. It existed, always. We couldn't see it unless orange bubbles started telling us the story. So until now, our goal was to improve the unit assignment process. We improvised. We shifted our perspective, and we said, no. We are going to focus on bed downtime. There is not only one variable affecting bed downtime, but there are 10 different variables affecting bed downtime. So the orange bubbles, it helped us shift our focus from what was actually the problem. Then came improvement opportunities because we all agreed that there is a bed downtime. Nobody could deny it because we presented facts. So we started huddling and we started talking about what opportunities we had to reduce the bed downtime. Guess what? We need more data. We can't identify opportunities until we have more data and more information. So we went back to observe. So there are some qualitative data, some quantitative data, some observation data. We mixed all the data, whatever data we could get, to make sure that we are hitting the right target. So we went there. We sat down there for the whole day, 7 a.m. to midnight. We divided our shifts. Our analyst, one analyst is right here, Rohit Toteja. We all went down and we all sat down, started, scribbling down everything that we saw in the process. And what we found is that between 7 a.m. and noon, only internal transfers are assigned. Between noon and mid-afternoon, few patients assigned, not from ED. From 3 to 7, I guess, Some more patients are assigned from different sources, not from emergency medicine. And right after 7 p.m., boom, all emergency medicine patients are assigned. Can you tell me why? It's the discharges. Discharges are not happening early in the morning. Remember the dashboard that I showed you? Oh, one more. And here are the barriers that we collected, that why we are not able to assign the patients, and the patterns were getting repeated. The provider team's not available, the provider himself is not available, the communication gap, the workload, the batching, and so many things. So once we had the information, the next one was to create a true north quadrant, right? You can't nilly-willy go and start implementing stuff. So what we decided is looking at the effort and impact. And this is where we landed. The arrowed interventions or the opportunity that we came up with is what we thought should be implemented. What emerged from True North Quadrant was the 4 work stream. We divided ourselves into 4 groups. Every group had a lead, and every group had a purpose. The first group was looking at the provider availability. That happened at the very executive level. The delays, I can't say from here, the delays that it contributed was that because we didn't have provider, we were not able to assign a bed because there were rules and regulations, and the admitting window and provider team is capped, and I can't take more patients, so on and so forth. The hospitalist selection process. Hospitalists have unwritten rules, unsaid rules that's been followed since the time of inception. I know you're facing the same challenges, yeah? And until they touch the patient and see the patient, they will not accept the patient. Even though the bed is available, the bed is clean right there. Then you have bed manager workflow. Bed manager workflow, again, they are following the unwritten rules because they have the workload. All the patients are coming at the same time to be assigned. There are so many tasks that they are performing, and so on and so forth. In the internal transfer process, we thought that the beds are being held for the internal transfer patients, and that's why we are not able to assign the bed to the patients. So now we had clear understanding of the problem and the intervention that we needed to mitigate, because most challenges were around processes and workflow. What's the better way of doing it? We decided to go lean and take the waste out of the process. We followed DMAIC. I'm not going to go through the entire DMAIC process, but it's define, measure, analyze, improve. Define your problem, measure your problem, analyze, find the improvement opportunities, and control and sustain your improvements. Interestingly, when I put DMAIC on my analytics life cycle, it's almost there. Everything is matching right there. So lean and analytics go hand in hand. We also designed A3. We had 5 A3s, 4 each for the work stream that we had, and the one overarching A3 to keep us on track of the bed downtime. We also created the SIPOC for the better understanding of the process. Who are our suppliers? What's the input? What is the process? What's the output? And who are our customers? We created decision tree. This is the very first iteration of decision tree. It looks very simple, but if I had to put the latest decision tree, your mind will go, wow. there are so many nodes and there are so many decision points that we identified. But decision tree helped us understand where our process was breaking down, where the bed managers had to stop doing everything that they were doing before they could assign a bed to a patient. So I talked about the barriers, right, in my previous slides. It was like list of barriers. So we categorized all the barriers, and there's no other better way of categorizing barriers but the fishbone diagram. We identified 8 categories, and we chose 2 each barriers for each category that can have the impact on the bed downtime. So we are at very initial phase of this lean project. It's been 3 months now. We just started. But we did implemented some intervention, very quick fixes that we thought that it's easy to implement and could be done very quickly. So the first one was standardized handoff. We saw that the bed managers were handing off, shift to shift information to each other in a very different ways. One bed manager would have a different paper, the worksheet, and different information than the other bed manager. And that was just creating problem. And we had seen through our analysis and data that there was a dip at 7 p.m. It's a shift change time, that there was no bed assigned. And we were figuring out why is that happening, and what we found was the handoff process that was taking so long. So we standardized how they did the handoff between 2 shifts. Then reducing number of huddles. Huddles are good. We talk to each other to get more information. But we weren't sure why a bed manager need to go to 3 or 4 huddles during their shift. Makes no sense to us. So we reduced the number of huddles that they went, and we brought it down to 1 huddle a shift. Reducing interruptions by reallocating the duties. Bed managers were like to-go person, like anybody in the hospital will call bed manager. My pager is not working. What is bed manager going to do about the pager? So we tried to filter all the phone calls that were going to bed managers so that they can appropriately take their calls that is pertaining to assignment of bed. Leveling their workload. We saw that people had preferences of what shifts they need to do, but as we brought this problem forward, we leveled the workload. If the bed were available more during the evening time, we made sure that we have enough bed managers to take care of the assignment process. But most importantly, pre-assigning providers. We had found during our observation that the beds not been assigned 80% of the time because provider team is not available or is capped. So what we did was we started assigning the provider team even before we know that the bed is available or not available or where the patient's going to go. And that helped us a lot to bring our process time down. So the benefits, are we seeing changes? Yes, we are definitely seeing changes. These are small interventions. These are very quick fixes that we could do on the fly, and we definitely are seeing changes in this through this initiative. Our pre-intervention data, 6 months of data set that we had analyzed to implement this project, had about 176, 177 minutes from bed request to bed assign, which went down by 30 minutes for my post-intervention data set that we were looking at. So it's by 30 minutes, 13% improvement. If you change a process by 30 minutes, it's a big deal. And sustain it is bigger deal. If you compare fiscal year to fiscal year, bed request to bed assigned, fiscal year 17 to fiscal year 16, we saw about 60 minutes difference. Definitely, it's a big, big improvement. We can see that we have taken out the waste from the process. And what is the better way of looking at any Lean Six Sigma project's outcome? Box plot. The more variable is the process, the more chances that your process is inefficient. So we plotted box plots using pre- and post-intervention data, and what you can see here, that we were definitely able to reduce the time. This is the 25th percentile, and this is 75th percentile. So 75th percentile is hitting 25th percentile of pre-intervention. In other words, 75% of the requests are assigned within 2 hours instead of 3 hours. We still have work to do. We haven't been able to squeeze this box down. We know we have work to do, and we have to take the variability out. As I mentioned, we are still in the initial phase of this project. So this is the initial pre-intervention data that we shared. 54% of the boarding time due to process, 46% bed wait time, and we changed it to 44% of the boarding time due to process, and 56% of the boarding time due to actual bed need to be available. We still have work to be done. We are not there yet. We need to see the effect of this process on our boarding time. Boarding time has many other variables that's affecting its time, but yes, we need to work. We have a lot of other interventions in place, electronic nursing handoff, provider handoff, transportation. We have converted almost every project into a Lean project now. So the story can't end without orange bubbles, right? So this was the pre-intervention bubble right here at the right-hand side. We moved that to left, and we shrunk the size. We still have a lot of work to be done. We want to move it a little more further and a little more smaller. And I think we will get there. Maybe not in next 2 months, maybe 6 months. So the last step of the analytics life cycle is to control and sustain your changes. And the best way of doing that is to distribute or to share the metrics with the users or the stakeholders or the process owner. And we created the True North Launchpad. And I'm going to quickly, are we doing good on time? And we are going to, I'm going to take you very quickly to the True North Launchpad right from here. We created this with Tableau. I have to pull this here. Hold on. Nope, this side. Okay. All right. So anyone who has worked with Tableau, we find ourselves sometimes getting confused about which dashboard is which one, which project, which folder, what am I looking at? And the way we came up with an idea as, how we can systematically categorize all the metrics that, even the senior leadership, if they want to follow, they would be able to follow it very easily. So the True North is the metrics that all the metrics that falls under the True North would be tracked here. Metrics related to emergency medicine, metrics related to capacity command center, metrics related to the declines from the patients coming from outside, the operational metrics, the metrics related to operation rooms, metrics related to discharges, and any initiatives that's going on right now. So if you click on emergency medicine, it gives you options. These are the metrics that we follow to track our emergency performance, emergency medicine's performance. You have, let me use my pointer. You have what is the metric, the name of the metric. You have definition of the metric, which is very important to keep everybody on the same page. This is the definition of the metric, period. Then what is the unit of the metric? Is it mean, median, percentage, whatever? And the frequency of the metric, frequency of the update, how often this metric gets updated, daily, monthly, quarterly, and so on and so forth. Where the data is coming from, it is very important. People and users always want to know where your data is coming from. And as much as you are transparent with them, they would not question your data. So let's say that I want to look at this dashboard, and I say, okay, I want to look at that one because there are a couple of dashboards that are reporting the same metric. If you click on that, it'll pull up. I can't wait for hyper. Sorry. And it pulls up the dashboard right from your desktop. You don't have to now go to Tableau server to figure out which project I have saved my dashboard, which workbook I need to pull up, and so on and so forth. This is Tableau. Everything is Tableau. What we have created is in Tableau, but in a way that it's easy for everyone to access and understand that what they are looking at. Let's go back one more, and I want to also, come on. When is Hyper getting released? 10 point, it's in beta. Oh, man. Okay.
You have to close the error box there.
Sorry?
There's an error there. You have to close the error box.
I can't see from here. Where is the error box?
Right in the middle.
Oh. All right, I'm going to, hold on, let me pull up the other one. All right. So the portion that you see here, it's the executive summary of what's going on right now with all the metrics. It's kind of elevated speech for C-suites that, if they don't want to bother us asking us data every 5 minutes, they can go to this and figure it out what's going on with all the metrics that we are following here. Again, I can't wait for NLG. I would love to have NLG embedded in this one. Here is our true north. I think that one. And again, this dashboard is in work in progress. We are still figuring out how best we can display data so that it's easy for users to access and understand and interpret. This is a quick summary of all the goals that I shared with you in my previous slides. The occupancy, length of stay, volume, OR hold, ED holds, so on and so forth. At a glance, if somebody needs to look at it, they just click on that and go from there. All right. I'm going to close it down. Okay. I can. Is that the one? Okay. It's difficult to see from here, and I can't move from here because I have to. All right. So that was True North. Everybody has access to it, whoever is part of our capacity management and whoever wants access to this True North Launchpad. Very transparent, very open. Anybody can get into it, ask us questions, and we would be happy to answer. So some teaching moments. Every initiative that you implement, you always learn something. Analytics is a game changer. Definitely it is, you know. We still debate if analytics is arts or science, and I think it's both, depending on the challenges that you are trying to address. It is a game changer in a sense that it helps uncover or discover the real problems and not just anecdotal hearsay. It takes a village. We worked as a team. You know, big projects like what we undertook here, it cannot be done in isolation. You know, we worked as a team. We leveraged all the expertise that we had at our disposal to make this project very successful. Every information is in play until there is an explanation for it. Do not discard any information. Do not until you have established causal effect or correlation, or you know why that information exists, because you never know when you will have a aha moment with the information that you have you know, gathered. Do not discard any information out of any project. Instilling lean as a philosophy in healthcare, we all know lean works well. We are trying to implement a lot of projects you know, through lean. We have seen in healthcare industry, it's very slow. The adoption of the lean is very slow. I don't want to get into the details about that. But yes, you know, the healthcare has the more processes and workflows than any other industry. And any inefficiency in healthcare could be addressed through eliminating waste. So yep, instilling lean thought is you know, what we thought is the better way of doing this project. And lastly, analytics provides you with the clear answers, right? We changed our perspective. We changed from our unit assignment process goal to bed downtime because we had analytics with us. I know I'm running out of time. And lastly, I want to thank you, my team that we worked with. Dr. Erin Kane, who is our Assistant Medical Director of Capacity Management Office, me, Laura Weiner, who is our Senior Director for Lean Sigma Deployment, Wilson Lemmy, who is the Senior Quality and Innovation Coach of Lean Sigma Deployment, Linda Huffman, who is a Process Owner for the Bed Managers, Jim Shulin, who is the Chief Administrative Officer for the Emergency Medicine and Capacity Management Office, Rohit Toteja, he's sitting right there, is the analyst on my team, and Mary Margaret Jacobs, who is the director of everything. That's what we call her. All right.
Awesome. Huge round of applause for Hetal.
Thank you.
So if it is any consolation, I've worked across 7 industries, including manufacturing, which is almost 12 years back. And when I used to say, you know, if Lean Six Sigma is used to make widgets in automobiles, shouldn't someone consider applying it in a healthcare context to save lives? And people would look at me funny and say I'm like from Mars. So don't be surprised. We have time for a few questions. Any questions for Hetal at this time? Okay. We'll just go down first. Okay, go ahead.
I just want to ask, is it live connection, or how do you use do you use like
Yeah.
extract data? How you getting data?
Yeah. So there are 2 ways we can do it. We extract, so we are Epic. We have Epic implementation of our system-wide, so we have access to Clarity if people are familiar with Epic and Clarity and stuff. So we pull data from Clarity and stage it on our server for it to be cleaned before we start putting stuff together. So it is a live connection to the database, but the data is not real time. 1 day. Yesterday's data, correct. But to answer your second question, do we have access to real-time data to something else? Yes, we do have access to real-time data through web services that we stage on our server and then pull up the real-time information.
So I just wanted to benchmark our journey against your journey, and we're early in our life cycle. Yeah, my name is Jay Pearson. I'm with the United States Pharmacopoeia, and we understand healthcare and some of the challenges that you face. But from the time you decided, or it was decided to implement Tableau in your environment until today, how long has that been? And the second part of that question is, how many people do you have focused on the analytics team within Johns Hopkins?
Wow, okay. So it's a big story of Tableau adoption in Johns Hopkins Hospital. To answer your question, enterprise-wide adoption of Tableau just took off about a year ago. I think a year ago, I guess. I'm not so very sure. But we have been using Tableau in different analytics teams since last 7, 8 years now. So when I joined Hopkins in 2009, we didn't have a good analytics tool. We had a couple of them. I don't want to name the name. We didn't find it intuitive, so we came across Tableau. And since then, since 2010, I have been using Tableau to do data discovery and many other things.
Any other questions? Okay, back there.
How many? Oh, now everybody has access to Tableau. Every analytics team would have access to Tableau in all 5 hospitals across Johns Hopkins.
I was just curious.
I can't tell you the exact number of analytics team. I would guess 200, 300, 400, I don't know. Do you know, Rohit? 200, okay.
Since you're using Epic and Clarity, how are you identifying bed holds due to OR-related issues?
How do I identify?
Yeah.
How do I identify what?
OR bed holds.
OR bed holds?
Related to the
Tricky
OR.
question. It all depends on your users using Epic in a way that you want them to use to get the data flowing into Epic and Clarity. So we reinforced our users to go into Epic and always say, hey, if you are on hold, please click on the hold so that we can understand that this patient was on hold. If they did not click on the hold, the other way we could identify the hold is the completion of the surgery time until the time the patient was out of the room or in bed. And we see that, there's a 15 minutes, we give them 15 minutes mark that if you pass 15 minutes, then you are on hold. Yep.
Any other questions? Okay, back there.
Earlier you mentioned that discharges after 2 p.m. you had less than 5%. Is that something that you guys have considered looking at to also help with this boarding time? Also with OR and PACU holds that I know you mentioned earlier, is that something that you looked at, or is that on the back burner for now?
No, the person, so everything depends on what happens on the inpatient units, right? If you don't empty your beds, you don't have other patients occupying the bed. So we are still focusing on how many patients do we discharge before noon, before 2 p.m. And our target is about, I want to say 10% before noon or about 15% before noon. We are finding it hard to achieve that target due to many reasons. We are teaching hospital, and as I say, the tripartite mission sometimes just gets in our, I don't want to say, it's difficult to balance it out, that we are a teaching hospital, we are #1 teaching hospital, I guess, I don't know. But it's a challenge for us.
Hi, you mentioned data transparency, and I'm wondering, with so much information that's been processed, there's always that question of, can I see where some of the examples of where these things have gone wrong? At what point, at what level do you actually provide that information, or is it kind of an ad hoc thing, or is it actually built into
Very
your
short
tools?
answer, whatever they want. We sit down with them, we go patient by patient. I remember we had a question about bed being dirty and bed being clean, and they were like, yeah, your data is not right. And I said, okay, let's sit down. We had 2-hour session. We pulled up all the patient level details and all the bed level details, and we went bed by bed, patient by patient, making sure that the stakeholders of the bed EVS process was satisfied to the point that yes, we are doing it the right way. So yeah, however they want, what you want is for them to trust you in your data. You just do whatever it takes. It depends. It depends. What kind of dashboards are we putting together and what's their need? But it depends. We try not to give PHI levels information out so easily.
I have a question regarding the impact of deploying the capacity command center from GE and how that linked to the whole initiative that you are doing, and technically how it links with Tableau.
So Capacity Command Center was deployed in February 2016, and I think now they are gone. It's up to us how we are taking the work that they had done. A really wonderful work that they have done. We have big monitors where we have all the real-time information flowing for the throughput of the patients, for OR, and whatever you name it that involves in throughput. But we are taking all the goals and objectives that we have established for ourselves for the better patient throughput and the better patient outcome, and just taking it from there one step at a time.
Awesome. So one last question from me. So have you named any of this or plan to name any of this the Toyota of healthcare?
I don't know. You have any suggestions?
I've seen that whenever other industries kind of adopt Lean Six Sigma, it's usually Toyota of CPG, Toyota of retail. So just something to consider. So with that said, a huge thank you and applause to Hetal.
Thank you. Thank you.